So there'd been 11 previously published studies on the effectiveness of Tamiflu. And Tamiflu, the generic name is oeseltamivir. And only 3 of those studies were ever published. And that concerned me because it made me wonder what was in those other 8 studies. There have been cases where manufacturers and others with a financial stake have selectively published the most favorable studies, and it made me think, what's in those other 8 studies? And there had been pressure to release the results of those studies, and so Roche had made the studies available, the FDA big reports available on their website. And so we downloaded those and started looking at them. And it turned out several of the studies probably shouldn't have been published. They were what we call a failed trial, where there were only 30 or 40 patients recruited. They set up the study, but then they were unable to recruit people or something fell apart. But there were 3 studies that were really interesting and I thought worthy of further study and important. I thought it was important that people know about them. One of the studies dealt with patients who had chronic heart or lung disease, and that's a really important group that was excluded from the published studies. We think that if it's going to help, if the drug is going to help, it's most important that it works in those chronically ill patients. They also did a study in the elderly, so they only included people over age 65. And again, that's another group where we think it's really important to know how well the drug works. And then they did a really big study, 1,500 patients, looking at treating within the first 24 hours versus treating in the 24 to 36 hour window. It's pretty clear that beyond 36 hours there's almost no benefit. So that was the motivation, was to look at those unpublished studies and see if that changed our assessment of how effective the drug is. Well, the main results, first of all, when we looked at those unpublished studies, the one that compared treating in the first 24 hours of symptoms compared with 24 to 36 hours, there was a lot less benefit in that 24 to 36 hour window. Only about 14 hours fewer symptoms if you got treated in that window compared with about 30 hours during the first 24 hours. Now, even 30 hours is not exactly a home run. It doesn't stop the disease dead in its tracks. But, instead of having the flu for maybe 6 days, you'd have it for 4.5 or 5. That may be worth something. The other studies, looking in the elderly and looking in those with chronic illness, actually showed no significant reduction in how long symptoms lasted. What we also did was we combined the data from all of the studies, which were all similarly designed, and looked at the impact of the drug on preventing hospitalization. That's a really important complication of the flu. Some people end up hospitalized, about 1% to 2%. And one of our assumptions was that people who took Tamiflu would be less likely to go into the hospital. We found that that just wasn't true. There was absolutely no difference in hospitalization rates. And then the third thing we looked at was the impact on complications. Now, previous researchers who were sponsored or related in some way to the manufacturer had included 4 things as complications of flu. Pneumonia, which is a real complication, otitis media or ear infection, sinus infection, and acute bronchitis. When you looked at that, altogether there was a small benefit, but acute bronchitis, we felt was not really a valid complication. It's a viral illness like the flu. It's self-limited. There's really no good way to diagnose it other than listening to someone's chest, and those patients might have just flu causing the changes in how the lungs sound. So we didn't think that was a really valid complication of influenza. And when you excluded that, there was absolutely no difference. Most of the so-called benefit was in those patients with acute bronchitis. There was a small benefit in terms of preventing pneumonia. You had to treat about 110 patients with confirmed flu to prevent 1 episode of pneumonia. But there's a catch there, and that is that when I'm treating someone in the office, I'm a family physician, I don't know 100% for sure that they have the flu. Only about half the people we treat with Tamiflu in the office typically have the flu or less. And if you look at the setting of a typical primary care setting or ER setting where they're dispensing Tamiflu for patients with suspected influenza, there was no difference in pneumonia rates. So we really found no difference in hospitalizations, no significant difference in complications. And then when we looked at the overall impact on how long symptoms lasted, which they had said was 30 hours based on the published data. We found it was closer to 20 hours when you looked at all the data. So overall, not nearly as impressive as we had assumed, and I think that's important for people to know. Well, I haven't been in touch with them. They haven't contacted me. I honestly don't know. There have been other groups around the world that are looking at similar data. There's a group led by a researcher named Tom Jefferson out in England, who's been doing some great work in this area and very important work, and they're trying actually to get what we call patient level data. So what we have now is the reports that tell us about, in aggregate, how did those 400 or 700 or 1,500 patients do. And what would be better is, because these studies were almost identical in design, is if you actually had individual patient level data, de-identified, we don't need to know who they are, but that way you could look at the impact by age group in more detail. You could look at the impact in terms of duration of symptoms in more detail, and so they're trying to get that kind of data. But no, they haven't been in touch with me. I haven't seen any Swiss people lurking around my house. Well, we certainly are in flu season, and Georgia is having some moderate activity right now, I think. The last time I looked, you can go to the CDC website. If you just Google CDC flu map, you can see if the flu is in your community. Typically, people with the flu, we've done some other studies that show that the most important things to look for are people have a fever and a cough, almost always. They have body aches. Usually it hits pretty hard and pretty quickly. If your symptoms develop over 3, 4, 5 days, it's less likely to be the flu. And people with the flu usually have chills or sweats. So if you have that kind of thing, you wake up, you feel like you got hit by a bus, fever, cough, you're achy, maybe you're having some chills and sweats. If you can seek care within 24 hours, then the Tamiflu may be helpful and might help you feel better a day or two faster. If it's beyond 24 hours, there's really relatively little benefit. Beyond 36 to 48 hours is essentially no benefit. And realize that the only benefit you're getting is, at best, you're feeling better about a day sooner. So it's not going to prevent, as far as we can see, complications. It's not going to make you feel better immediately. It'll just make you feel better a little faster. And I don't want to give the impression that the only thing we can do is Tamiflu. I think you can get a lot of the same benefit by resting, staying well hydrated, taking an anti-inflammatory like ibuprofen or Aleve, and laying low, and most importantly, trying not to go to class or go to work so you prevent spreading it to other people.